Hello and welcome to a Pilates hour today with Polestar. We're going to be looking at wrist fractures. So welcome. We're expecting a big group today. Seems everybody likes to come in on the case studies, so we're going to have some fun with that. So let's get started. And just a little shout out, it's as crazy of a time as it is in the world. This is the time for us to be a beacon of light as healers, as movers, as movement instructors. We have a great team of practitioners around the world. We're over 800 people signed up for this webinar today, and that makes me super happy to know that we're able to reach out and send out good messages, good learning. I hope that you're enjoying it. Melissa and I have also been trying to diversify the webinars, so we hope that you like that. Going from different professions, different angles, different interactions. We would love to hear from you. So at any time that you are thinking of ideas, you think of something that might make this webinar great, or ways that you would invite more friends if we did this or that, please let us know. You can write it in the chat if you want. Melissa can pick it up. You can also just write to us of topics or things that you would be interested in us discussing. And again, this is an interactive webinar, so it's for you, and I get all the benefits of doing some of the research and the prep. Always benefits me too, so it's a mutual thing, sort of like a mentorship that we talked about last week. I hope those of you that joined us last week really enjoyed that. These were two individuals that are sort of heroes of mine in the rehabilitation world that have really brought evidence-based practice into physical therapy. And we have learned from them, and we have been trying to bring evidence-based practice into our Pilates so that we really can be justified as a medical and a therapeutic and a wellness intervention to improve the quality of life of our clients. And I always like to talk with things as a spectrum, not as just a black or white, but the idea that it's a continuum. And some Pilates teachers have more experience in rehabilitation, post-rehabilitation. Some physical therapists have more experience in wellness. And it's just a continuum, and we need to respect that and communicate. And it was great to see Adrian and John really realizing the power that we as Pilates teachers have as it pertains to the continuum of care. And this is just a really powerful place. And I like that about the case studies, especially this case study we're going into. As a matter of fact, when we talk about, sort of this continuum of care, we in Polestar discuss stages of rehabilitation. And in stage one typically involves immobilization, which is what this case was about. So somebody who fractured their wrist, Elaine, 44-year-old woman, while she was rollerblading. And of course, with that fracture, she was put into a cast. And that cast was on for 6 weeks, and then a brace. And now she's about 8 weeks out, and she's coming to us. She's been doing Pilates for years. She wants to get back in her groove. She knows Pilates. She's very conscious of her body. She loves to be outside, super active, and wants to return to her Pilates and her gym workouts. And her primary complaint as she comes to us is the stiffness that follows being in a cast for 6 weeks. And again, if you think about it, while the injury is in the cast, that's the immobilization stage. That's stage one. The tissues are healing. The bone is mending. So there's nothing we really want to do while the tissue is mending. However, when she comes out of the cast, the question is, what now? So if we go into a stage two, our goal is to introduce movement with non-destructive force. So what that means, what that means is that we are now grading load. So we've talked a lot about this, and I want you to think about it as we go through Elaine's case, is that we are manipulating the load to be able to increase tolerance and function. So when we look at a stage 2 injury in Polestar's protocol, stage 2 means we're introducing movement with non-destructive force. Well, how much force does it take to be destructive? And I think this is it's a hard question. As a physical therapist, I can't tell you, well, it's always going to be 10 pounds of pressure following this kind of an injury. And it's just not true. It might be that, one person is 5 pounds, one person is 10 pounds, one person is 30 pounds. It's different with every individual. And for that, we have to be able to do testing to see what their tolerance is. And sometimes we test them too hard. So a mistake we make quite often in the medical world is we test them a little too hard. They could be sore for 4 or 5 days instead of maybe for 24 hours or a couple hours. So that's something we got to keep in mind. So we're going to take a look at some subjective insights about Elaine. And when she was asked in her subjective interview, what do you believe you should be able to participate in, right? Our common question. She says, look, I'm super active, as you know, and want to be able to participate in all my outdoor activities, including hiking, swimming, camping, as well as my conditioning and training activities. Now, when I think of that, most of her outdoor activities don't require her to use her hand or her arm, other than maybe setting up a tent or putting a backpack on her shoulders. But the fact that she might have a fall, or you could think of future falls, or she trips or slips, or hiking, that happens quite often, is her wrist stable enough to bear her weight? So you have to think that hiking, just because we use our legs to do hiking, we're not 4-pod animal hikers, that we would make sure that she can tolerate load. She specifically mentioned in her exercises that she wants to be able to do push-ups, pull-ups. She does like CrossFit, where they have the band and the band goes underneath the feet and she can work on her upper body strength. She likes to do weights. She, of course, does Pilates, and she likes to take yoga. So then when I asked her the second question, what do you believe is stopping you or preventing you from participating in the above? It was very simple. I'm just not able to tolerate much weight without pain on my right wrist. And so she's already trying to put some weight through that wrist, and she's having some pain. Here's our first question, and this is the same question we always ask. That is, before assessment, based on subjective information to this point, what would you hypothesize Elaine needs the most right now? And keep it simple. Like, what does she need? What is she experiencing that, based on what she wants and the little bit that you know about her, what do you think is the most important thing that she wants? And it's always interesting when we look at just how the individual's desires are going to predict our decisions if we do it correctly. I have a comment here from Sarah Edwards. She's, hi, Brent. Can you remind us of the model of rehab you're describing? I certainly can. In Polestar, we use a model that was originally developed by Porterfield and Carl DeRosa. Matter of fact, I have the book on my shelf. It's called Mechanical Low Back Pain. And what they did is they broke down orthopedic problems, musculoskeletal problems, into 4 levels or 4 stages. The first stage was what I mentioned was not doing any harm to the tissue. So we're basically immobilizing the tissue, and it usually is related to pain or tissue damage that it needs to heal. The second stage I mentioned is introducing non-destructive movement with non-destructive force. So really starting to introduce new movement. It's a mobility time. We do this a lot in Pilates because we have graded load. And then number 3 is functional restoration, sort of moving from that foreign to familiar environment. And then number 4 is establishing or educating limits. Now, Porterfield and DeRosa talk about limits as them establishing the limits. In Polestar, we talk about the limits being something established within the awareness and consciousness of our client. So it's asking the client, what do you feel? When you feel that pressure, that's telling you that you're going far enough. If you don't feel that pressure, you're not going far enough. If you go too far, you're doing harm to yourself. So we believe in creating the limit and the limitations coming from internal, not external. Let's see what you guys said. Feel safe she won't fall, confirmation the fracture is healed, gentle mobilization and strengthening movement that can be load adjusted, empathy and encouragement, great wrist mobility, mobilization. I'm seeing a lot of mobility and range of motion up here. That's great. I think you're already barking up the right tree. That's also going to give her, she's pretty aggressive, right? I mean, she's super active. She likes to be outside. She's not as afraid of her wrist not healing. She just wants to make sure that she can get out there and be aggressive again in her outdoor activity. Great answers, everybody. And I do think getting confidence back without a doubt that she knows that she could go down and pick herself back up using her hands and her arms. So an objective assessment. The medical test came back and it showed that the x-ray 8 weeks out, fracture is well healing. There's lots of good callousing around the fracture site. And she's been cleared for introduction of movement and strengthening into the fractured area, into the upper extremity. Let's go to the next slide. And the physical therapy assessment objective measures are as follows. And I think this is important to understand. It's nice when, as a team, we can talk to each other and explain things. It's sort of like, even though it might be out of the scope of practice for a Pilates teacher to declare an actual range of motion or to do some of the assessment, it doesn't mean that you can't understand what that range of motion implies. So for example, her active range of motion, that's the movement that she could do herself with the right wrist, she had decreased extension and flexion by about 30% and more pain in extension. So you think of anything that we're doing weight bearing on the hand, she was about 30% shy. So let's think of what that looks like. If 90 degrees is flat, like she's putting her hands on the ground and she's weight bearing, that would be 100% of the range of motion. So if I said 30% or 30 degrees shy, right? That means that she would be somewhere around a 60-degree angle. So you can imagine if her wrist doesn't go further than this and she puts all her weight on it, she's going to be putting a very large force right on the carpal bones in the wrist that could be causing her some discomfort and pain. Second, she had poor tolerance to weight bearing on the right hand. So her trying to get into quadruped or even putting her hands on the treatment table and leaning into that was probably somewhere around 40 to 50% of her body weight without pain. So I want you already thinking mobility and load that we're talking about here. And we're going to think of how we can modify things for Elaine to be able to successfully return to her Pilates activity so the rest of her body can be staying in shape as her wrist heals and as we also progress her to have more range of motion, more strength. She was limited in some strength, and that's normal following a fracture, especially coming out of a cast and a brace. We have what's called disuse atrophy. So disuse atrophy is not that the muscle disappears. Sometimes people think the muscle fibers actually disappear. In this short of a period, if the muscle doesn't have a demand, it just shrinks. And then as soon as the demand is placed on it again, it hypertrophies again. So you'll notice quite often with inactivity, let's say that we hit the gym hard and we buffed up and our biceps now are 16 inches and they're just ripped. And then we don't work out for a year or a couple of years even. As soon as I go back into the gym, I start lifting weights again, the hypertrophy of that muscle returns to what it was at its peak very quickly. To increase it up to like 17 or 18 inches might take a lot of work and some more time to get it back up to there. So we refer to that as disuse atrophy. She definitely has some weakness. When we use the numbers, 5 out of 5 means that she could resist a full strength force on her wrist extensors would be a 5 out of 5. A 3 out of 5 means that they cannot lift it against gravity. So they couldn't lift their hand up against gravity. These measures came from the polio epidemic and back in the early 1900s, when physical therapists and doctors would be able to measure how bad the impairment was from the virus. So if the virus caused the weakness that they couldn't lift their hand up against gravity, but if they turn it sideways, they could still have extension. They might be under a 3 out of 5 or a trace, right? So she was not that weak. She was a -4 with her wrist extension was the worst, and a little bit better with flexion and pronation, supination, both were a 4 out of 5. So definitely able to get strength back with some practice. She had no loss of neurological signs or symptoms. So her reflexes, her tactile, her sensory were all normal. And that's not always the case with the wrist fracture. So you think if you have two really important nerves that run through the wrist. On the thumb side is the median nerve, and that takes care of the first 3 fingers. And on the pinky side is the ulnar nerve. And sometimes the fractures in the wrist can cause problems to those nerves. So she was clear with the nerves, and all of her fingers were working and all the bones working correctly, good circulation, which also should not be taken for granted. What functional tests would you want to do with Elaine? So just think about it, answer the question. You know what she has a limitation, you know her complaint, you know what her activity level is, you know where she wants to return to. Where do we go from here? So take a moment and think of some of that. And again, functional tests, it does not have to be the Polestar assessment tool test. It does not have to be the Polestar screening. I just want you to think of functional tests that would make the most sense of what you'd be looking at, that she would need to be able to demonstrate to be able to return to her full activities of push-ups, pull-ups. What were some other things that she wanted to do? Lifting weights, doing her yoga and Pilates. So think of your Pilates exercises. Think of the limitations she had in her range and also in her strength. What would you want to test? How would we want to know how far is she away from being able to participate in those activities? While you fill that out, I was going to just let everybody know that next week, I've invited Juan Nieto to be my guest. And many of you know Juan. Juan is very well known in the Pilates industry. He's known in the running world and Runity. Juan has developed one of our specialty courses in chronic low back pain and movement, and he'll be joining me. So we're going to just have a heyday next Thursday, talking about chronic low back pain, talking about movement, talking about neuroscience, biomechanics, bio, Pilates, as we talked about with Adrian Lowe a little bit. And by the way, Adrian Lowe is coming back in 3 weeks, and he's going to be joining me to talk about pain, everything pain. So we'll have some fun with that. Let's see what you guys have as far as your test. Let's put the test up and see what you're thinking. So wall push-ups, I like that. That's a nice one. Grip strength, good, good. Rotation of forearms, so looking at the pronation, supination. I see a quadruped position, very good. Her own weight bearing in different variations, maybe with some support and without, and in different angles. Looking at rotational movement, prone shoulder flexion, right? So getting on the ground and seeing how she does with her arms. I'd even look at maybe the pre-swan with her hands down on the floor. Could she do pre-swan even if she couldn't do a full swan? Somebody put, can she open a child-proof bottle? I can't open the child-proof bottle. Modified wrist circles, sustained wall press. Again, there's a couple of you that put wall presses or wall push-ups. That's a great idea. It's not full body weight, it's partial body weight. And we said that she's somewhere between 40-50% of her body weight. We sort of guessed with her ability to use the table. Somebody put dumbbells and light weights. So we talked about the weakness in the wrist, not being able to, she could move it through the range, but particularly wrist extension was weak. So we could look and test and see how much weight she could actually move through that range. Very good. Great baselines. Thank you for participating in this. Functional assessment. I did a quadruped with her, and I did a kneeling push-up just to look to see what she could do. And in my assessment, she had very poor tolerance without assisting lifting the heels of the wrist, the heel right here of the wrist. 30 degrees. So I just had to be able to lift the heels up. So I put a pad. You could take a pad and put, I don't know if you can see that, but a pad and put a pad underneath the wrist. I'm sorry, we have so much pollen up here in North Carolina right now that if I don't stop and sip some water, the pollen will get the best of me. But I found that 30 degrees of an angle, we knew that she was limited about 30 degrees, but 30 degrees was enough to take away the need for assistance and got rid of the pain that she was having in her wrist with weight bearing. And in the kneeling push-up with a hand on the edge of the mat, same thing, prevented in-range wrist extension. She was able to do a kneeling push-up with minimal discomfort. So that was important to me to know because she wanted to get back and be able to do things with the foot bar on the reformer. She wanted to be able to, hold on the foot bar, the tower bar. She likes to use the equipment a lot. Also, I tested side lift to see if there was any residual problem in the shoulder or the forearm, which she didn't have any problem with that. All weight bearing upper extremity tests required a modification about 30 degrees. So just keep it in mind now, and you might want to write that note down, that if we modified her range of motion, she didn't need a lot of modification on load. If we didn't modify mobility, then she needed assistance with load. I'll repeat that. If we were doing our movement with her and expecting her to have a full load, she needed a 30-degree lift underneath the heel of the hand or on the bar. That's why the Pilates foot bar is so great, is we can position the hand in different positions that she can have some friction that can hold her hand on and make it so that she can do the exercises without being in a full wrist extension. We also know that we can use pads, mats. The edge of the Pilates mat is great. For example, this picture of Shelly here. If we ask Shelly to turn her hands out a little bit and let her fingers drop down on the side, we immediately made that compensation for the range of motion that Elaine is not able to go into. So with this knowledge now, right, of what she can do, what do you believe could help Elaine be able to weight bear on the upper extremities without so much pain? And be thinking of all of her exercises. What are things that you could use in your exercises to make this work for her? I'm looking over to see, we have a question while you're doing that. This is Evie. She says, is it possible to fold the mat and put her hands with the heel on it so she has no pain? And that's exactly what we're looking for right here in this question. So you're right on the money, Evie. So we can fold mats, we can use anything that is going to reduce, or like anything that is a weight bearing. For example, I've seen people even use some of the small hand weights and use the hand weights to be able to do the push-up activity. So she seems to be pretty fine in that neutral range of motion, that mid zone, without going into extreme wrist extension, or obviously we wouldn't do push-ups unless we're at Ido Portal on the back of the hand. I don't know if any of you ever tried that. I tried it. I saw some videos of Ido Portal, and they were doing full push-ups on the back of their hands on the ground in flexion. And so I thought it would be a good idea to try it and see how it felt. And I personally didn't care for it very much. You can try it and give me your opinion. Let me know what you think. I think my old hands from treating patients for 30 plus years, there might be a little too much discomfort in there, but I'm going to keep trying. Obviously, we can do it. Was not comfortable. Let's see what people are throwing up there, Melissa. Keep putting your answers up. Let's see what you think about different modifications, because this is the trick, right? With a modification with Elaine, we can pretty much return her to full activity because she's in good shape. She knows Pilates, she knows the gym. We just have to be able to work with her in that 30-degree range of motion without the pain. So I'm seeing some great things here. Wedges for hands, the moon box, yoga blocks, quadruped on a long box so the hand can go around the box, mat or pad under the wrist heel. D or half roll, perfect. Half roll is great. Hand in straps on all positions, nice. Modify arm position, hands more forward, right? So thinking of on the foot bar, on the tower bar, or even on the mat, if the hand is forward and the shoulders in a little bit more flexion, that's less extension on the wrist. So you have to see if they can tolerate the load in the shoulder. Here you can do any quadruped positions using the bar or the reformer to limit range of motion. And this is part of the beauty of our Pilates environment, isn't it? We have so many, think about the chair, right? You could do the swan on the chair because the pedal's out in front and it's sort of sticky, and we could keep the hand in a middle range and still have the ability to go into swan and swan one and to do rotation and some of the other advanced exercises through the hand, just because of the curve of the foot pedal. And the same thing on the reformer, the same thing on the tower bar, the same thing in all the straps on everything. All of the boxes allow the hand to hang off the side. She doesn't have any acute pain in central weight bearing. The discomfort and pain is only when she goes beyond that 60 degrees of wrist extension. Great ideas. We'll share these ideas with those that come to this later on. So now, this is really simple. I want you to think about what we've talked in the past. Remember, for Elaine, what principles would we prioritize after her physical therapy? So she's coming to you as Pilates teachers, post-rehab, wants to get back on the apparatus, wants to get back in shape, wants to go to the gym. We look at the principles of breath, of mobility, of alignment. We look at the principle of load and control and movement integration. As we look at those, where do we put our priority as Pilates teachers? What do we want to try to gradually get back? And is this a control issue? Is it a load issue? It's probably a combination of some of them. Let's wait till we get a few more answers in here before we turn it live. Again, anybody that's out there in the cyberspace and you're not on the Mentimeter, give it a go, give it a try. Let's see how your answers match up with others and see what you experience with that. The reason why we use the principles of movement is because it really guides us. And this is a straightforward one, everybody. This is one that you already know the answer to. If you just think about it, you've already said it multiple times, that the modification is there because of this particular limit in this principle. Let's go ahead and see what people are saying. Very good, very good. So you're allowed to put multiples up, and of course there are some important factors here. I would probably say, without a doubt, mobility is the first and foremost. And then I would say the second one is probably control, because remember, control is about load. So she might need a little bit of work with load, although it seems that she can handle full load in neutral zone. But when we go into an end of range, which we're going to do because we want to start increasing her range, we can start playing with more load and control. So we can grade that load up. We can challenge the control of that wrist. We often talk about in yoga, the bandhas. This would be the Mansi Bandha, the bandha around the hand and the wrist, which is a co-contraction. And in her ability to do that, she could actually increase her stability in her wrist, just like we all could as we do any hand weight bearing activities. I have some good healthcare advice coming in, and she is absolutely right. But Famita said you need to diffuse lemon, lavender, and peppermint for the pollen. And I am going to do that because I have it. We have our essential oils and our diffusers, and I'm going to do that next time. So you're going to have to call me on that, Famita, to make sure I do that. Sarah Edwards has another comment. I've had clients who had recently had surgery for cubital tunnel syndrome over on the ulnar side. And some of these approaches are also appropriate for her, I think, in terms of progressive load, and mobility. And I think this is the take-home message for any of these. Thank you, Sarah, for sharing that. Is, Elaine, in this particular case, we're looking at a wrist fracture that's healed up well. She's 44 and she's doing great. She's returning to her activity, really no limitation. She truly is a mobility case with some modified load. But think about it with somebody that has carpal tunnel syndrome or just weak wrist. Like, there are so many clients that come to us with weak wrist and they try to get into some of those positions and it's very hard for them. These are great ways to modify their ability to participate. So getting a little bit of lift of the wrist, a little assistance, teach them how to place their hands on the bar can really make a difference and allow them to have a successful movement experience. Melissa George said, would the co-contraction fall under the movement integration principle? And yes, it would be part of that. It's also part of control. If you think of, and here's a good exercise to try. I love this one. If you take your hand and you put it on the ground, or the surface, you're going to basically push the hand down and the fingers down and lift the wrist up. And what that's going to do is give you that little tunnel underneath the hand, and that creates a co-contraction. So lifting the fingers is going to, or pushing the fingers down is going to be a flexor force, and lifting the wrist up is going to be an extensor force. So the two of them together is called a bandha that's going to create a co-contraction around the wrist. That certainly could fall into awareness and proprioception in proper motor organization or motor control or motor learning. So it definitely would fall under movement integration. It also would fall under control, like a co-contraction around a joint, to have enough stiffness around that joint to execute the movement correctly and safely. Another comment came in from Jenny Adams. She says, can you give us a bit of guidance about how soon to get somebody back to Pilates post-surgery? During stage 1, are we okay to do supine leg and rest of body work to avoid being deconditioned? Fantastic question, Jenny, because that's exactly what we should be doing, right? So let's say somebody has a cast on their arm or their leg. Typically, it's absolutely fine to continue modifying their program, but to let them exercise on the equipment as much as possible while they're in a resting state for that injury. The more that we can keep the shoulders and the trunk and the lower extremities healthy, the faster they're going to rehabilitate, without a doubt. So now we're looking at, based on the information today, what would you incorporate for Elaine? What exercises would you do for her? And again, I want you to think for a second. Maybe the better question is, are there really any limitations if we have the right modifications? That could be the take-home buzz sentence of today. Are there any modification, or are there any limitations with the current modifications? Let's see, I have another chat coming in. It says, I often encourage my students who are mostly senior, 55 plus, that's me, to bring whatever they need for their comfort when doing the mat work on floor. It's a great idea. Trying to see, that's Catherine Connor. Thank you, Catherine. And i.e. pillows, cushions, towels. I agree with this 100%. Anytime we can make the client a little more responsible for their own comfort. For example, even if I'm teaching a reformer class, quite often I'll tell somebody, this is where the pads are. This is where the pillows are. You need to have a pad right now. As you get better and better, we can maybe get rid of it or decrease the size of it, but just bring it with you when you come into class. Don't make me have to remind you every time. Give them a responsibility to make sure that they have that capacity. So going back to timeline, right? There was a timeline that was asked in that question. Everybody's different. Every surgeon is different. Some surgeons are very, very protective. They're very afraid of some horrible thing happening. And typically it's not going to be with a Pilates exercise, but it might be somebody's in the Pilates studio and they trip over the Allegro and they fall down on their hand and they injure their wrist again. The reality is we can't control every single possible accident. This could be happening at home. It happens while they're walking their dog. I always tell people to be very careful of walking their dog after they've had surgery. They don't realize how many people fall down from walking the dog. If they don't have a well-behaved dog, like a lot of you probably don't, have dogs that every once in a while see a cat and they go running, or another dog and they pull on the leash. And if your wrist has just had surgery and you're holding in that hand, everything's fine, and they run. Or if you hurt your hip and had the hip surgery or something like that, it's like it quite often happens with the unexpected surprise load on the body. We can't really prevent that other than just trying to increase consciousness and make good decisions about what we do with our bodies and when we're in that healing stage. What we can do, though, is understand that the more we prep the body for the unexpected. So, for example, when somebody's coming back from, let's say, a knee surgery, I don't just train the knee in the sagittal plane, even though that's its normal movement pattern. The knees get hurt typically in the coronal or rotatory plane of movement, or combined planes. So one of the things I want to do is make sure that very early on, we're introducing very gentle forces into other planes of movement and accessory motions of that joint, so the tissues can heal up and be resistive. A lot of work that we see in like Ido Portal, if you ever want to see some really phenomenal play movement and body exploration, the whole premise is that as the body explores movement, the tissues adapt. As the tissues adapt, we become more supple, more pliable, more resistant to forces, decreased risk of injuries, etc. So a really cool idea. So when we're working with our clients coming out of surgery, two things. One, make sure you know what the physician or the doctor has asked for. Be compliant with that. You don't need to make any enemies in the community. And two, we start introducing forces with non-destructive force. That's where we start. That's a stage 2. And we see how they do. And as they do better, then we start introducing them into functional movements. And those could happen sometimes in the same visit, or sometimes it could be months apart. But we set those limits. And then the last one for is setting limits, right? So we do that. All right, let's see what people are saying. What are some exercises? And hopefully the gist of it is, you know what, there's nothing that she can't do with that, as long as she has a modification for the wrist extension. So as long as she has a modified hand position, she can participate in most of her exercises. Again, closed chain exercises, and I'm seeing those, the elephant, wall press, elbow planks, working on all fours, leaning back and forth, gradually leaning into the load. These are all fantastic ideas in her exercises, right? And we want to gradually load the tissues in a way that she is comfortable, that she is able to challenge the tissue a little bit. And I often use this kind of phraseology. I want you to move into resistance and then come back at it. So we're going to touch it and go. I call it my touch and go, right? I don't want you to go into pain. You go into resistance. So even as a manual therapist, when I'm learning manipulation or teaching manipulation, I teach them to go into resistance and then come back out of it. You can feel the resistance. That's what we want to feel in her wrist, is that resistance. Now, as long as we're continuing to load that tissue with that level of challenge, the tissue is going to adapt, meaning she's going to get more range of motion, and she's going to get more and more independent and need modification less and less. So as Pilates teachers, listen carefully, we're going to introduce this kind of a force without ever going into a painful state. That's why we can tell our patients and our clients, we're not going to do any tissue damage while you're in Pilates. We're just not going to do it. We're not going to take you to a place that would put so much load through a tissue that it would actually tear or rupture the tissue or fracture a bone. We're just not going to do it. And the way you know that is because we only load to the point that you feel resistance. As long as we stay within that parameter, you are not going outside of your scope of practice. And that level of resistance is what is going to be the best mobilizing force for long-term increased mobilization of that joint until we get to a functional range of motion. So again, bring your questions on. It'd be good to see some more questions about that. This is a very important concept. We've talked a lot about in some of our cases about the idea of how breath facilitates and can impede movement quality. We've talked about dynamic alignment and how we want to make sure we have the proper biomechanics in the joint. For example, we've talked a lot about the knee and the hip mechanics and the foot mechanics. We've talked about load and we've talked about mobility. They all go together in movement and movement integration. But here in particular, we often delegate the idea of mobilization to a manual therapist or doctor. And what I'm saying is that gradual load over time will also increase range of motion. We talk about stretching the muscles. The load can also change the restriction of connective tissue, scar tissue, capsules, and even ligaments. The way you stay within our scope as Pilates teachers is we don't go beyond pressure, like that load of pressure. We feel the pressure in that tissue and we stay there for a little bit, we work there, and then we come out of it. We never push into the painful state of it. That way you don't have to worry about it. There's times where I push into the painful state as a licensed physical therapist. And as my son used to tell his friends, I have a license to inflict pain, but I'm not going to do tissue damage. And as Pilates teachers, we don't need to go to pain ever, right? So we just need to go to pressure. So in summary, with Elaine, we're looking at limitation to weight bearing in that right upper extremity due to decreased range of motion. So we really know that mobility is the limitation here, and particularly in wrist extension to be able to handle the load. We also know that her load was full in a more neutral position. So if the hand was on the foot bar or the tower bar or the foot bar of the chair or on the edge of the block, she could bear her full body weight through the wrist. That's not always the case, right? So what would be different if Elaine couldn't bear the weight through her wrist in a neutral position? Well, we not only would have a mobilization challenge, but we would have a load challenge. So we would have to modify the load even more. So a lot of you had similar exercises, but just know that your emphasis might be more on modifying the load by changing the angle or light springs or what you decided up against a wall. Wall's a fantastic way to manipulate load, decrease it, is that they can put their hands on the wall and that diagonal, they can put, 30% of their weight through it without a problem. In this case, she didn't have a load issue as much as she had a range of motion or mobility issue. Number two, she probably still needs treatment by a PT, chiropractor, occupational therapist, really working on that mobility, maybe getting in there doing some manual therapy to be able to get the carpal bones to glide over the fracture site. And that requires expertise and specialty. You don't want to be messing with that. Number three, modification of range of motion on all weight-bearing activities in the Pilates repertoire, which you eloquently defined in your programming. So we talked about all the sort of cool ways that you could do that. And then the most important part, and the one that we often forget, is the idea of decreased modifications as the client's tolerance to range of motion increases, right? So we don't have to stay there. I know a lot of times we sort of figure out, oh, always bring this wrist modification when you come to class. The goal is to get her to where she doesn't need a wrist modification. So that typically, if we're doing our job right, could happen 3 to 6 months out from a fracture like that she actually is getting her full range and a full tolerance and a full load and would not need a modification. And that's just a guesstimation on average of clients that have had this type of a fracture of the radius. All right, so any questions on that from the summary? If that sort of feel like it resonates, I feel like you were able to identify very clearly your objectives. I know that you understood the idea of modifying the range of motion by your answers on the modifications. They were excellent. And then picking the exercise was also very good, knowing that that's how you're going to be able to restore the motion. And the last thing would just be make sure that we're not stuck in that modification. Make sure that we know that we're going to keep adding more pressure, a little more function over time, and get it so she doesn't need a modification or a very minimal modification at most. I do have another comment here. It's from Julian. And Julian says, I have a client with lipedema, which is affecting her ankle mobility strongly. She has pain in her wrist and cannot find 90 degrees weight bearing in her wrist without pain. All mobility and modifications have not shown improvement. Would I be right in thinking her condition is affecting her wrist also? And that it certainly could. I mean, if you're in an inflammatory state or a fluid retention state, it can certainly limit the range of motion, and it can also cause pain, right? The inflammatory response can cause pain. The fluid can cause limitations in mobility. So if there's something systemically going on, it could affect a lot of different joints in the body, even though the diagnosis was looking primarily at the foot. It could be the knees and the hips and the hands as well with something like lipedema. Okay, so that's a great question. And again, just thinking it, the beauty of what we can do with somebody with lipedema is we can create modified loads and modified ranges of motion. And that's really got to be our adjustment. So with her or him, I would say we're going to focus more on control with load modification in the inflamed or swollen state than we would focusing necessarily on mobility only. And we would see that if we can manage the load and she can successfully move without too much discomfort, her load and her range of motion are going to get better. There was a question from Catherine Connor in the chat. Would you recommend a flexible wrist brace while healing and recovering? And she was already in a bit of a wrist brace, and absolutely. I think more than anything, the wrist brace, I'm even okay if she's in a rigid wrist brace for another month or two when she's out and about, or if she was to go camping again. Why? Because all it takes is one silly slip and fall while you're healing. And if you have that brace on, the brace is going to protect the fracture site that's healed up. And typically we don't break in the same place that we healed. So this is not uncommon that somebody would have a second fracture to the same area, but the callousing of the fracture, even 8 weeks out, often is stronger than the bone around it. So if her radius had been repaired and had gotten strong and calloused, the fracture might happen just above it or just below it if she was to have another fall again. So I'm totally in favor of being safe and having a brace. A lot of times physicians will do this, for example, with low back fusions. The fusion itself is very sturdy and going to heal just fine, but they'll wear a brace for months just to make sure that nothing crazy happens, like a slip and fall in the ice or a car accident or other things that just happen, that they protect them. And so it's not a bad idea, especially when you go into a foreign area, somewhere you haven't been, stairs and things you're not familiar with, or you go someplace where there's an icy ground. You certainly want to be protected and safe for them. All right. Well, I think that concludes our discussion today, unless you have more questions. And we actually ended on time. We're a couple minutes before the end of hour. I haven't done that for a while. I thank you for your patience. Again, I want to remind you of a couple things that are coming up. Obviously, Polestar always has its education running, and now we have our MAT and our reformer courses online. So a lot of people have been expressing to me how much they love taking the reformer online with Shelley and Nicole, because it's giving them a lot of new ideas of ways that they can teach group classes and things that maybe they didn't think about when they were back in the day learning exercises. The other important thing is that a lot of times we forget about all the advanced and intermediate exercises, and we sort of get stuck in a certain repertoire. So it's a nice way to go back and build that up again. We also have the advanced courses that are going on. So I'm getting ready to teach the critical reasoning course again. That's going to be 3 days. Again, it's live only. You can come out to the farm. You can camp on the farm if you want, or stay at a local Airbnb. And we just have a good time in person, working with real people, touching, hugging, assessing, learning all those great tools. I haven't quite figured out how I'm going to make it virtual, but it's like what we do every time we get on a case study on steroids. So if any of you are interested, we would hope that you would come join us, and we'll make every possible provision we can that you would have a great, safe experience here on the farm. So it'd be really cool to have you here. Next week, I mentioned I have Juan Nieto with me, and we're going to be talking about chronic back pain and movement. And so we really want you to join us for that. We think that we're just going to it's going to be really interactive. It's going to be your questions. So if you have questions about working with clients with low back pain, and especially chronic low back pain, please send those questions in to us ahead of time. You'll see the call for them when Melissa sends out the invitation by the beginning of next week. But if you already have questions, you have clients, think of those clients and start writing out your questions for Juan and for me. Juan designed and built the course, Movement and Chronic Low Back Pain. Of course, my love for working with chronic low back pain. That was the essence of my dissertation, was creating the positive movement experience and the psychological aspect of pain. So both of us are really hip on that literature. We'll be there for that. We'll send out the links for the critical reasoning course, Debbie, on the post program. So just keep an eye on that. And you could also go to the Polestar website and you could find that information. The Juan's course also is available online. It is a virtual course. It is a great course. It's being taught in New Zealand, in Australia, in the UK, and now in the United States. And if you want to take that course, it's available. And of course, for free, you get to come hang out with us next week. And I'm going to ask him a bunch of questions. You can ask us questions and we can participate together. The last thing, we want to let you know that we had a fantastic course with Beth Kaplanik. She had a sellout course of over 40 people came to her orthopedic course for knee and hip. So we're really excited. If any of you were able to come to that course, thank you. And we hope that you enjoyed it. You can share it with friends. It'll be back up probably in about 6 months. And I can't think of anything else to share with you other than today's a good day to be good. So think of how we can be kind, how we can share the thing with you, and just believe in the fact that love exists. Love will always conquer hate and anger. We can be good in our society. And I will see you next week with Juan Nieto, end of the month with Adrian Lowe. Shelley's back on in 2 weeks for a special session while I'm taking a little R&R to try to practice what I preach. I did see something come from Christine about the FRS International Congress in Montreal. I'm not planning on it, but could you give me some more information, Christine? I'd like to know more about it. And just send it to me or to Melissa and let us know what's going on there, if it's something that we'd like to attend or to participate in. Thank you, everybody. As I said, it's a good day to be good.